Dengue fever is a mosquito-borne tropical disease caused by the dengue virus. Symptoms typically begin 3 to 14 days after infection. This may include a high fever, headache, vomiting, muscle and joint pains, and a characteristic skin rash. Recovery generally takes less than 2 to 7 days. In a small proportion of cases, the disease develops into the life-threatening dengue hemorrhagic fever, resulting in bleeding, low levels of blood platelets and blood plasma leakage, or into dengue shock syndrome, where dangerously low blood pressure occurs. Dengue is spread by several species of mosquito of the Aedes type, principally A. aegypti. The virus has 5 different types. Infection with one type usually gives lifelong immunity to the type, but only short-term immunity to the others. Subsequent infection with a different type increases the risk of severe complications. A number of tests are available to confirm the diagnosis, including detecting antibodies to the virus or its RNA. A novel vaccine for dengue fever has been approved in 3 countries, but it is not yet commercially available. Prevention is by reducing mosquito habitat and limiting exposure to bites. This may be done by getting rid of a covering standing water and wearing clothing that covers much of the body. Treatment of acute dengue is supportive and includes giving fluid either by mouth or intravenously for mild to moderate disease. For more severe cases, blood transfusion may be required. About 500,000 people require admission to hospital a year. Non-steroidal anti-inflammatory drugs such as ibuprofen should not be used. Dengue has become a global problem since the Second World War and is common in more than 110 countries. Each year between 50 and 528 million people are infected and approximately 10,000 to 20,000 die. The earliest descriptions of an outbreak date from 1779. Its viral cause and spread were understood by the early 20th century. Apart from eliminating the mosquitoes, work is ongoing for medication targeted directly at the virus. Signs and symptoms. Typically, people infected with dengue virus are asymptomatic or have only mild symptoms such as an uncomplicated fever. Others have more severe illness, and in a small proportion it is life-threatening. The incubation period ranges from 3 to 14 days, but most often it is 4 to 7 days. Therefore, travelers returning from endemic areas are unlikely to have dengue fever or other symptoms start more than 14 days after arriving home. Children often experience symptoms similar to those of the common cold and gastroenteritis and have a greater risk of severe complications. Though initial symptoms are generally mild but include high fever, clinical course. The characteristic symptoms of dengue are sudden onset fever, headache, muscle and joint pains, and a rash. The alternative name for dengue, breakbone fever, comes from the associated muscle and joint pains. The course of infection is divided into 3 phases: febrile, critical, and recovery. The febrile phase involves high fever, potentially over 40 degrees Celsius, and is associated with generalized pain and a headache. This usually lasts 2 to 7 days. Nausea and vomiting may also occur. A rash occurs in 50 to 80% of those with symptoms in the first or second day of symptoms as flushed skin, or later in the course of illness, as a measles-like rash. A rash described as islands of white in a sea of red has also been observed. Some petechiae can appear at this point, as may some mild bleeding from the mucous membranes of the mouth and nose. The fever itself is classically biphasic, a saddleback in nature, breaking and then returning for 1 or 2 days. In some people, the disease proceeds to a critical phase as fever resolves. During this period, there is leakage of plasma from the blood vessels, typically lasting 1 to 2 days. This may result in fluid accumulation in the chest and abdominal cavity, as well as depletion of fluid from the circulation and decreased blood supply to vital organs. There may also be organ dysfunction and severe bleeding, typically from the gastrointestinal tract. Shock and hemorrhage occur in less than 5% of all cases of dengue. However, those who have previously been infected with other serotypes of dengue virus are at an increased risk. This critical phase, while rare, occurs relatively more commonly in children and young adults. The recovery phase occurs next, with resorption of the leaked fluid into the bloodstream. This usually lasts 2 to 3 days. The improvement is often striking, and can be accompanied with severe itching and a slow heart rate. Another rash may occur with either a maculopapular or a vasculitic appearance, which is followed by peeling of the skin. During this stage, a fluid overload state may occur. If it affects the brain, it may cause a reduced level of consciousness or seizures. A feeling of fatigue may last for weeks in adults. Associated problems. Dengue can occasionally affect several other body systems, either in isolation or along with the classic dengue symptoms. A decreased level of consciousness occurs in 0.5 to 6% of severe cases, which is attributable either to inflammation of the brain by the virus, or indirectly as a result of impairment of vital organs, for example, the liver. Other neurological disorders have been reported in the context of dengue, such as transverse myelitis and Guillain-Barré syndrome. Infection of the heart and acute liver failure are among the rarer complications. A pregnant woman who develops dengue may be at a high risk of miscarriage, as well as low birth weight and premature birth. Cause. Virology. Dengue fever virus is an RNA virus of the family Flaviviridae, genus Flavivirus. Other members of the same genus include yellow fever virus, West Nile virus, street, Louis encephalitis virus, Japanese encephalitis virus, tick-borne encephalitis virus, Chiasanua forest disease virus, and Omsk hemorrhagic fever virus. Most are transmitted by arthropods, and are therefore also referred to as arboviruses. The dengue virus genome contains about 11,000 nucleotide bases, which code for the 3 different types of protein molecules that form the virus particle, and 7 other types of protein molecules that are found in infected host cells only and are required for replication of the virus. There are 5 strains of the virus called serotypes, of which the first 4 are referred to as DENV1, DENV2, DENV3 and DENV4. The 5th type was announced in 2013. The distinctions between the serotypes are based on their antigenicity. Transmission. Dengue virus is primarily transmitted by Aedes mosquitoes, particularly A. aegypti. These mosquitoes usually live between the latitudes of 35 degrees north and 35 degrees south below an elevation of 1,000 meters. They typically bite during the early morning and in the evening, but they may bite and thus spread infection at any time of day. Other Aedes species that transmit the disease include A. albopictus, A. polynesiensis and A. scutellaris. Humans are the primary host of the virus, but it also circulates in non-human primates. An infection can be acquired via a single bite. A female mosquito that takes a blood meal from a person infected with dengue fever during the initial 2 to 10-day febrile period becomes itself infected with the virus in the cells lining its gut. About 8 to 10 days later, the virus spreads to other tissues, including the mosquito's salivary glands, and is subsequently released into its saliva. The virus seems to have no detrimental effect on the mosquito, which remains infected for life. Aedes aegypti is particularly involved, as it prefers to lay its eggs in artificial water containers, to live in close proximity to humans, and to feed on people rather than other vertebrates. Dengue can also be transmitted via infected blood products and through organ donation. In countries such as Singapore, where dengue is endemic, the risk is estimated to be between 1.6 and 6 per 10,000 transfusions. Vertical transmission during pregnancy or at birth has been reported. Other person-to-person modes of transmission have also been reported, but are very unusual. The genetic variation in dengue viruses is region-specific, suggestive that establishment into new territories is relatively infrequent. Despite dengue emerging in new regions in recent decades, predisposition. Severe disease is more common in babies and young children, and in contrast to many other infections, it is more common in children who are relatively well nourished. Other risk factors for severe disease include female sex, high body mass index, and viral load. While each serotype can cause the full spectrum of disease, virus strain is a risk factor. Infection with one serotype is thought to produce lifelong immunity to that type, but only short-term protection against the other three. The risk of severe disease from secondary infection increases if someone previously exposed to serotype DENV1 contracts serotype DENV2 or DENV3, or if someone previously exposed to DENV3 acquires DENV2. Dengue can be life-threatening in people with chronic diseases such as diabetes and asthma. Polymorphisms in particular genes have been linked with an increased risk of severe dengue complications. Examples include the genes coding for the proteins known as TNF-alpha, mannan-binding lectin, CTLA4, TGF-beta, DC-sign, PLCE1, and particular forms of human leukocyte antigen from gene variations of HLA-B, a common genetic abnormality, especially in Africans, known as glucose-6-phosphate dehydrogenase deficiency, appears to increase the risk. Polymorphisms in the genes for the vitamin D receptor and Fc-gamma are seen to offer protection against severe disease in secondary dengue infection. Mechanism. When a mosquito-carrying dengue virus bites a person, the virus enters the skin together with the mosquito's saliva. It binds to and enters white blood cells, and reproduces inside the cells while they move throughout the body. The white blood cells respond by producing a number of signaling proteins, such as cytokines and interferons, which are responsible for many of the symptoms, such as the fever, the flu-like symptoms, and the severe pains. In severe infection, the virus production inside the body is greatly increased, and many more organs can be affected. Fluid from the bloodstream leaks through the wall of small blood vessels into body cavities due to capillary permeability. As a result, less blood circulates in the blood vessels, and the blood pressure becomes so low that it cannot supply sufficient blood to vital organs. Furthermore, dysfunction of the bone marrow due to infection of the stromal cells leads to reduced numbers of platelets, which are necessary for effective blood clotting. This increases the risk of bleeding. The other major complication of dengue fever, viral replication once inside the skin. Dengue virus binds to Langerhans cells. The virus enters the cells through binding between viral proteins and membrane proteins on the Langerhans cell, specifically the C-type lectins called DC-sign, mannose receptor and CLAC5A. DC-sign, a non-specific receptor for foreign material on dendritic cells, seems to be the main point of entry. the dendritic cell moves to the nearest lymph node. Meanwhile, the virus genome is translated in membrane-bound vesicles on the cell's endoplasmic reticulum, where the cell's protein synthesis apparatus produces new viral proteins that replicate the viral RNA and begin to form viral particles. Immature virus particles are transported to the Golgi apparatus, the part of the cell where some of the proteins receive necessarily sugar chains. The now mature new viruses are released by exocytosis. They are then able to enter other white blood cells, such as monocytes and macrophages. The initial reaction of infected cells is to produce interferon, a cytokine that raises a number of defenses against viral infection through the innate immune system by augmenting the production of a large group of proteins mediated by the JAK-STAT pathway. Some serotypes of dengue virus appear to have mechanisms to slow down this process. Interferon also activates the adaptive immune system, which leads to the generation of antibodies against the virus as well as T cells that directly attack any cell infected with the virus. Various antibodies are generated. Some bind closely to the viral proteins and target them for phagocytosis, but some bind the virus less well and appear instead to deliver the virus into a part of the phagocytes where it is not destroyed but is able to replicate further. Severe disease. It is not entirely clear why secondary infection with a different strain of dengue virus places people at risk of dengue hemorrhagic fever and dengue shock syndrome. The most widely accepted hypothesis is that of antibody-dependent enhancement. The exact mechanism behind ADE is unclear. It may be caused by poor binding of non-neutralizing antibodies and delivery into the wrong compartment of white blood cells that have ingested the virus for destruction. There is a suspicion that ADE is not the only mechanism underlying severe dengue-related complications, and various lines of research have implied a role for T cells and soluble factors such as cytokines and the complement system. Severe disease is marked by the problems of capillary permeability and disordered blood clotting. These changes appear associated with a disordered state of the endothelial glycocalyx, which acts as a molecular filter of blood components. Leaky capillaries are thought to be caused by an immune system response. Other processes of interest include infected cells that become necrotic, which affect both coagulation and fibrinolysis, and low platelets in the blood, also a factor in normal clotting. Diagnosis. The diagnosis of dengue is typically made clinically, on the basis of reported symptoms and physical examination. This applies especially in endemic areas. However, early disease can be difficult to differentiate from other viral infections. A probable diagnosis is based on the findings of fever plus 2 of the following: nausea and vomiting, rash, generalized pains, low white blood cell count, positive tourniquet test, or any warning sign in someone who lives in an endemic area. Warning signs typically occur before the onset of severe dengue. The tourniquet test, which is particularly useful in settings where no laboratory investigations are readily available, involves the application of a blood pressure cuff at between the diastolic and systolic pressure for 5 minutes, followed by the counting of any petechial hemorrhages. A higher number makes a diagnosis of dengue more likely, with the cutoff being more than 10 to 20 per 1 inch. 2. The diagnosis should be considered in anyone who develops a fever within 2 weeks of being in the tropics or subtropics. It can be difficult to distinguish dengue fever and chikungunya, a similar viral infection that shares many symptoms and occurs in similar parts of the world to dengue. Often, investigations are performed to exclude other conditions that cause similar symptoms, such as malaria, leptospirosis, viral hemorrhagic fever, typhoid fever, meningococcal disease, measles, and influenza. Zika fever also has similar symptoms as dengue. The earliest change detectable on laboratory investigations is a low white blood cell count, which may then be followed by low platelets and metabolic acidosis. A moderately elevated level of aminotransferase from the liver is commonly associated with low platelets and white blood cells. In severe disease, plasma leakage results in hemoconcentration and hypoalbuminemia. Pleural effusions or ascites can be detected by physical examination when large, but the demonstration of fluid on ultrasound may assist in the early identification of dengue shock syndrome. The use of ultrasound is limited by lack of availability in many settings. Dengue shock syndrome is present if pulse pressure drops to 20 mm Hg along with peripheral vascular collapse. Peripheral vascular collapse is determined in children via delayed capillary refill, rapid heart rate, or cold extremities. While warning signs are an important aspect for early detection of potential serious disease, the evidence for any specific clinical or laboratory marker is weak. Classification. The World Health Organization's 2009 classification divides dengue fever into two groups: uncomplicated and severe. This replaces the 1997 WHO classification, which needed to be simplified as it had been found to be too restrictive, though the older classification is still widely used, including by the World Health Organization's Regional Office for Southeast Asia as of 2011. Severe dengue is defined as that associated with severe bleeding, severe organ dysfunction, or severe plasma leakage, while all other cases are uncomplicated. The 1997 classification divided dengue into undifferentiated fever, dengue fever, and dengue hemorrhagic fever. Dengue hemorrhagic fever was subdivided further into grades IV. Grade I is the presence only of easy bruising or a positive tourniquet test in someone with fever. Grade II is the presence of spontaneous bleeding into the skin and elsewhere. Grade III is the clinical evidence of shock. Grade IV is shocks so severe that blood pressure and pulse cannot be detected. Grades 3 and IV referred to as dengue shock syndrome. Laboratory tests. The diagnosis of dengue fever may be confirmed by microbiological laboratory testing. This can be done by virus isolation in cell cultures, nucleic acid detection by PCR, viral antigen detection of specific antibodies. Virus isolation and nucleic acid detection are more accurate than antigen detection, but these tests are not widely available due to the greater cost. Detection of NS1 during the febrile phase of a primary infection may be greater than 90% sensitive, however is only 60 to 80% in subsequent infections. All tests may be negative in the early stages of the disease. PCR and viral antigen detection are more accurate in the first 7 days. In 2012, a PCR test was introduced that can run on equipment used to diagnose influenza. This is likely to improve access to PCR-based diagnosis. These laboratory tests are only of diagnostic value during the acute phase of the illness, with the exception of serology. Tests for dengue virus-specific antibodies, type SIG and IgM, can be useful in confirming a diagnosis in the later stages of the infection. Both SIG and IgM are produced after 5 to 7 days. The highest levels of IgM are detected following a primary infection, but IgM is also produced in reinfection. IgM becomes undetectable 30 to 90 days after a primary infection, but earlier following following reinfections. Dengue, by contrast, remains detectable for over 60 years and, in the absence of symptoms, is a useful indicator of past infection. After a primary infection, it reaches peak levels in the blood after 14 to 21 days. In subsequent reinfections, levels peak earlier and the titers are usually higher. Both Dengue and IgM provide protective immunity to the infecting serotype of the virus. In testing for Dengue and IgM antibodies, there may be cross-reactivity with other flaviviruses which may result in a false positive after recent infections or vaccinations with yellow fever virus or Japanese encephalitis. The detection of Dengue alone is not considered diagnostic unless blood samples are collected 14 days apart and a greater than four-fold increase in levels of specific Dengue is detected. In a person with symptoms, the detection of IgM is considered diagnostic. Prevention depends on control of and protection from the bites of the mosquito that transmits it. The World Health Organization recommends an integrated vector control program consisting of 5 elements: advocacy, social mobilization and legislation to ensure that public health bodies and communities are strengthened, collaboration between the health and other sectors, an integrated approach to disease control to maximize use of resources, evidence-based decision-making to ensure any interventions are targeted appropriately, and capacity building to ensure an adequate response to the local situation. The primary method of controlling Egypt is by eliminating its habitats. This is done by getting rid of open sources of water, or if this is not possible, by adding insecticides or biological control agents to these areas. Generalized spraying with organophosphate or pyrethroid insecticides, while sometimes done, is not thought to be effective. Reducing open collections of water through environmental modification is the preferred method of control. Given the concerns of negative health effects from insecticides and greater logistical difficulties with control agents, people can prevent mosquito bites by wearing clothing that fully covers the skin, using mosquito netting while resting, and/or the application of insect repellent. However, these methods appear not to be sufficiently effective, as the frequency of outbreaks appears to be increasing in some areas, probably due to urbanization increasing the habitat of Aegypti. The range of the disease appears to be expanding, possibly due to climate change. The vaccine. As of December 2015, there is no commercially available vaccine for dengue fever. One that is partially effective is predicted to become available in Mexico, the Philippines, and Brazil in early 2016. It received approval in December 2015. The vaccine is produced by Sanofi and goes by the brand name Dengvaxlia. It is based on a weakened combination of the yellow fever virus and each of the 4 dengue serotypes. 2 studies of a vaccine found it was 60% effective and prevented more than 80 to 90% of severe cases. This is less than wished for by some. There are ongoing programs working on a dengue vaccine to cover all 4 serotypes. Now that there is a 5th serotype, this will need to be factored in. One of the concerns is that a vaccine could increase the risk of severe disease through antibody-dependent enhancement. The ideal vaccine is safe, effective after 1 or 2 injections, covers all serotypes, does not contribute to AD, is easily transported and stored, and is both affordable and cost-effective. Anti-Dengue Day. International Anti-Dengue Day is observed every year on June 15th. The idea was first agreed upon in 2010 with the first event held in Jakarta, Indonesia in 2011. Further events were held in 2012 in Yangon, Myanmar in 2013 in Vietnam. Goals are to increase public awareness about dengue, mobilize resources for its prevention and control, and to demonstrate the Asian region's commitment in tackling the disease.